It's the Pain Exam Podcast with your host, David Rosenblum, MD. If you treat pain or have an interest in pain management, join us as we discuss painful disorders, alternative treatments, practice management, and more. Be sure to subscribe to the Pain Exam newsletter at painexam.com and review the podcast on Stitcher or iTunes. Our high-yield premium episodes are now available on the Pain Exam app with a premium subscription or access for free with a CME subscription at painexam.com. And now, without further ado, here's your host, Dr. Rosenblum.
Welcome back and Happy New Year. Some good stuff coming up. First of all, we redid the Pain Exam website. It's at NRAP Academy. So you could type in painexam.com and that will guide you to where all my quiz and educational materials are now kept at the nrappain.org website. That's nrappain.org. It's a much more user-friendly platform. So if you need CME credits, or if you want to study for the boards, or if you want to do the virtual pain fellowship, we have PM&R, anesthesia, and of course pain management lectures, board review questions, and tutorials on regenerative medicine, ultrasound-guided interventional pain, and regional anesthesia as well. So I hope to see you guys there. And if you're on my LinkedIn or my Instagram, you could just type in Pain Exam or my name, you'll find me. I'm also releasing links to free content such as the radiology cheat sheet. So if you're not signed up to the newsletter, make sure you do, whether you're on the website or you do it via my social media. There'll be links, so just check it out. And of course, we have our monthly ultrasound courses. The next one is January 6th, which we do have spaces available if you're interested. January 6th is right after the New Year. It's going to be a smaller course, more intimate. So if you happen to be in New York or you can come to New York that weekend, it's going to be a lot of fun. I also have a course in Miami during President's Week, in case you happen to be in Florida and you want to learn ultrasound or escape your family or get some sort of, business expense for your trip. Check me out. The event calendar is on the website. Just look under ultrasound training at nrappain.org or Pain Exam. You'll see the events link. And I am going to West Virginia to help with the West Virginia Society of Interventional Pain Physicians at their meeting, talk about ultrasound as well as run a ultrasound course on Sunday. So if you can make it to West Virginia, it's a great hotel, the Greenbrier, very famous hotel, and I did it last year. I spoke there. It was a lot of fun. So sign up before the spots are all taken. So the hip joint is one of those joints where I'm more likely to throw in the towel after a couple of injections don't work and tell the patient to just get their hip replaced. With the knee and the shoulder, I feel like I have a lot more wiggle room because the knee, you have your geniculars, you can ablate them. You could also do PNS, easier than the hip. The shoulder, I'd say I don't do really many ablations of the shoulder, but PNS is a big one in my practice, and I've seen a lot of good results from people who've either had their shoulder replaced or need their shoulder replaced. I've also done biologics, PRP, bone marrow aspirate, visco supplements into the shoulder and knee joints with very good results. The knee, for some reason, the hip, for some reason, I feel is more of a challenge. And it could be the nature of the innervation, as well as the anatomy of the joint. So after one of my colleagues was asking me about doing a PENG block, the pericapsular nerve group with Phenol, I didn't really have much experience with it, but I've thought of it, and I have done a cryoablation there, and unfortunately my results were not as good as my partner's results, but my partner was doing something a little differently than I did, so I'm going to try that next time. Anyway, I found 2 articles on this, and they were patients with palliative, being seen for palliative reasons, and unfortunately both patients died fairly shortly after the blocks. I don't think it was related to the blocks. It seemed like it was more their malignancy and DVT. But anyway, one of the cases, the patient is 82-year-old with a pathological left hip fracture. And by the way, the PENG pericapsular nerve group is the anterior articular capsule of the hip, innervated by the articular obturator branches, the accessory obturator nerve, and the articular femoral nerve branches. So you're trying to limit the weakness that you would get with a regular femoral or obturator nerve block, I suppose. Anyway, this patient was referred to the pain service, and she had a survival shorter than 6 weeks, so I figured, gave the clinicians here a little more confidence that they can do a phenol block without ruining her chances of playing tennis. And the patient was already on buprenorphine, paracetamol, and Lyrica. So they offered her the neurolytic PENG block, and she stopped her anticoagulant 3 days prior. And they didn't do any diagnostic block, and I kind of understand that. If the patient's palliative and to just drag her back and forth, I think on exam, if the hip is truly arthritic and you have cancer in the hip joint, if it's or pathological fracture, I don't think you really need to waste too much time with that. Anyway, they put the ultrasound over the anterior inferior iliac spine aligned with the pubic ramus to identify the iliopubic eminence, femoral artery, iliopsoas muscle, and pectineus muscle. By the way, the pictures of this are in the link that I will share with you. They use a 10 centimeter 22 gauge spinal needle advanced in lateral to medial direction to place the tip in the musculofascial plane between the psoas tendon anteriorly and the pubic ramus posteriorly. They injected 10 mL of 6% phenol in 5 mL aliquots while confirming adequate fluid spread. Complete relief was obtained within 30 minutes. There was no motor weakness documented. 2 weeks later, the patient continued to have pain relief. And unfortunately, the patient passed away 2 weeks later. And this was related to a DVT. She happened to have pain prior to her passing only in the popliteal area of her leg, which was related to the DVT, in which a lumbar plexus block was offered. Well, just as an aside, I do a lot of injections into the popliteal area. I have patients with Baker cysts or posterior knee capsule pain. And what I often will do is what I call an articular branch of the tibial nerve block, which many other people refer to as an IPAC block. And so that could have helped with this. But anyway, side note, it really does, of course, depend on where the pain was located, because you're with the IPAC block, you're not going to get any motor or sensory really down to the lower leg. You just get the posterior capsule over the knee, but sometimes the popliteal fossa will also get some relief. So just something to keep in mind. Anyway, in terms of hip cancer-related pain, there's descriptions in literature about doing a neurolytic fascia iliaca block or femoral neurolysis, but of course that could cause motor dysfunction of the quadriceps muscle or anything in that femoral nerve distribution. To the knowledge of the author, this was the first neurolytic PENG block being used to treat cancer patients. I mean, what I'm really interested in is using the phenol to treat osteoarthritis patients. And unfortunately, I'm not finding much in the literature on that. But what I did find is an article referring to treatment of chronic hip arthritis with intra-articular phenol, not the PENG. Here it's a case report of a 77-year-old female, severe left hip degenerative joint disease, severe pain upon walking, and she could not go for surgery because of COPD. She's also bipolar, alcohol abuse, and multiple falls. And she had advanced degenerative joint disease in the left hip with complete destruction of the articular cartilage and long-standing associated deformity of the femoral head and acetabulum, but no AVN, no avascular necrosis. The left side obturator block performed with 10 mL of 0.75% ropivacaine gave relief within 24 hours and it improved the range of motion, but she had cramps in the leg and knee pain. The relief only lasted a few days, and she had a lot of pain with increasing amounts of oxycodone being used to treat the pain. They discussed neurolysis, and the problem with the neurolytic obturator nerve block was the decrease in mobility. So they decided or considered the phenol injection into the joint itself, and they used an image intensifier to, as I think they're referring to as C-arm, to get into the joint. And they used 3 mLs of 6% aqueous phenol with good spread throughout the joint. And they did 2 further injections of 0.5 mLs of phenol with periarticular coverage on the anterior surface of the joint. In 24 hours, she reported that her pain had improved with some movement demonstrated in the left hip. Her main complaint was now left leg cramps and left knee pain. And she was able to move her legs without complaining of pain in the hips. She was able to transfer with a pickup frame with one assist, weight bearing through the left leg. Her only complaints were of heel and feet pain and leg cramps. Due to the improvement, oxycodone was no longer required. She was discharged to high-level care accommodation on her pregabalin and buprenorphine. She was referred to pain management unit again exactly 12 months later after an increase in her hip pain and reduced mobility. And she had significant pain in both hips. And then they injected her under fluoroscopy with another 3 mLs of 6% phenol, which provided good coverage across the joint. And the pain, the spontaneous pain significantly decreased, and she became less distressed with improved weight bearing and transferring, and she was discharged again. So this is an interesting case because honestly, when I think of neurolysis, I think of neurolysis, killing nerves, not killing joints, but you're actually probably just killing the articular branches distal in the joint in this case. Anyway, because there are nerve endings there. So really interesting approach. In fact, the articular version, the phenol might destroy the joint, but the joint's already gone, and it actually might give you a more targeted approach. What I would be interested is comparing the PENG neurolysis with the hip joint neurolysis. I think that'd be very interesting to see. So they go into a discussion about phenol in this article, which I will give you the highlights. Phenol is a carbolic acid, phenic acid, phenolic acid, and phenyl hydroxide, hydroxybenzene, oxybenzene, highly soluble in organic solvents such as alcohol and glycerol, can be diluted with saline, and compatible when mixed with radiocontrast dye. So you could use it with fluoroscopy to make sure it goes to the right spot. But ideally, you probably want to give the contrast prior to injecting because this is a neurolytic, right? It destroys the nerves by inducing protein precipitation. There's a loss of cellular fatty elements, separation of the myelin sheath from the axon, and axonal edema. It has an immediate local anesthetic effect due to its immediate selective effects on small nerve fibers. Its differential blocking ability is believed to be the result of small vessel destruction that initially spares large fibers. Phenol in low concentrations acts as a local anesthetic, and in higher concentrations is neurodestructive. 6 to 10% solutions can be used in aqueous solution with glycerol. It is not painful to inject and has variable duration of days to months. The effects of the block cannot be evaluated until 24 to 48 hours to allow time for the local anesthetic effects to dissipate. The neurolytic effect may be clinically evident only after 3 to 7 days. If inadequate pain relief is obtained after 2 weeks, there may be incomplete neurolysis and required repetition of the procedure. Fibrosis can occur following the phenol injection, making nerve regeneration more difficult. Sensory nerve fiber density in the bone remains intact with advancing age despite loss of bone mineral and strength. As chronic low back pain, the correlation between X-ray changes and pain experience in osteoarthritis of the joint is poor, and it's been suggested that painless osteoarthritis is a feature of fibrosis of the nerves as part of the disease process with loss of axons. The nerve growth factor is secreted within the osteoarthritic joints and is associated with increased angiogenesis in the regenerating cartilage, which accompanied by the small unmyelinated nerve fibers developing. The presence of nerve growth factor also sensitizes the nerves to noxious stimuli. So they did a study that they quote here where they injected 6% phenol for SI joint pain in patients who had 2 to 4 weeks of relief after doing the injection with steroid and local. Then they had to repeat with phenol, and they used 6% with 2.5 mLs per joint, and 20% had greater than 70% improvement with an average duration of 24 weeks. Just keep in mind, if you're injecting a neurolytic substance into the SI joint, if you happen to go too far anterior or not be adequately placed in the joint, you may actually get the sciatic nerve. I often tell people that you don't need to be such a sharpshooter with the SI joint because sometimes the ligaments over the joint are inflamed or irritated, and you may actually be benefiting the patient if your PRP or steroid spills on these ligaments outside the joint. But with phenol, I would not recommend that. You want to be right on, right? Because you do not want to risk getting motor fibers of larger nerves such as the sciatic nerve or other motor nerves in the region. Lumbar facet syndrome, they injected phenol, and it looks like they're doing it exactly into the joint, not the medial branch block, and they showed that there was some good relief at 1 month with a single block. At 36% of the patients were having relief after 6 months. And then they described, then they talk about how this is the first phenol block in a major joint, and it's kind of interesting. I think I don't think I'm going to be really injecting it into the joint just yet. I want to see a little more data. Maybe for severe cases to do, well, I'm thinking about the PENG, but then again, maybe the joint is safer, right? If the joint is already gone, you probably have a lot more safety by just getting it in the capsule and nowhere else. Anyway, I think it's really interesting how this real old school drug is something that like I couldn't even get in the hospital when I was doing a lot of neurolytic cases. There was always alcohol. Now I have a bottle sitting on my desk in the pain office, and I've used it for neuralgia paresthetica. Unfortunately, I have a refractory case I'm dealing with, and it didn't really help her too much. In this case, I mean, this woman's 10 years out, failed. I'm beginning to think it's like a complex regional pain syndrome type of patient where she's unfortunately had, prior to meeting me, she's had radiofrequency ablation, she's had surgical decompression, she's had the Sprint device, the 2-month peripheral nerve stimulator. She had the Bionus device, which is the permanent device, which was implanted and then removed. She's had a cryoablation, she's had phenol ablation, and she's still suffering. So I don't mean to digress too much, but phenol was something that I thought would be the end-all be-all to save her, and now I'm thinking she might need a DRG or some other therapy for her chronic pain, as I believe the nerve is highly sensitized in this case, almost like a CRPS-like syndrome. Anyway, thanks for listening. Please rate the podcast, review the podcast if you like it. If you don't like it, just tell me what's wrong with it. And check out the new website, nrappain.org. There's a lot of free content there also, like the ultrasound stuff. And I'm trying to make this a bigger resource for you. And I'm always looking for volunteers and people to help me grow the platform, as well as get your names out there if you're applying for pain fellowship and you're trying to network, etc. I think there's really, we're probably practicing one of the best specialties in medicine. It's highly rewarding and a lot of fun. So thanks for listening. Please share the podcast. Tell your friends about it. And I hope to see you guys at my courses or the conferences. This episode was inspired by one of my students at the last course. His name is Abdul Aziz, who came all the way from Saudi Arabia to New York and spent the day learning ultrasound. So I wanted to thank him for coming to the course as well as for leaving this great testimonial.
Hi everyone, my name is Abdulaziz Karaji. I'm from Saudi Arabia, pain specialist and cancer pain specialist, working at Security Forces Hospital. I've enjoyed the course today with the ultrasound workshop. It was really refreshing. I learned lots of new stuff, and I would like to thank Dr. David for his contribution and patience. Thank you everyone. I wish you a Happy New Year. Thanks.
Dr. Rosenblum is here solely to educate, and you are solely responsible for all your decisions and actions in response to any information contained herein. These podcasts are not intended as a substitute for the medical advice of a physician to a particular patient or specific ailment. You should regularly consult a physician in matters relating to yours or another's health. You understand that this podcast is not intended as a substitute for consultation with a licensed medical professional. Copyright 2017, David Rosenblum, all rights reserved. No part of this publication may be reproduced, stored in a retrieval system, or transmitted in any form or by any means, electronic, mechanical, recording, or otherwise, without the prior written permission of the author.